I'd like to welcome everybody to Pulmonary Grand Rounds. My name is Luke Davis. Can everybody online hear me? Looks like we're getting a thumbs up there. So today it's my great pleasure to introduce today's distinguished speaker, who's Dean Megan Ranney, an emergency medicine physician, an expert in gun violence, and a public health leader, and the dean of our School of Public Health, which is newly independent as of October 1st. So we're very happy to have Megan here today. Megan earned her BA from Harvard College and then spent a year as a Peace Corps volunteer in Ivory Coast before going on to medical school at Columbia. She did a residency in emergency medicine and was chief resident at Brown and did a master's in public health before joining the faculty there. Megan has made research a major focus of her career, focusing on the intersection between public health and emergency medicine. And so her work has addressed mental health and then more recently gun violence and other forms of violence. And she's used a lot of innovative methods in terms of engaging lots of folks outside the academic sector in the community and thinking about how digital health innovations can have an impact on this major public health problem. She has over 200 peer-reviewed publications and has multiple NIH and CDC funded R01s. At Brown, Megan also distinguished herself by thinking outside of the university to establish a number of interesting organizations, notably the American Foundation for Firearm Injury Reduction in Medicine, known as AFFIRM, which is an organization that includes more than 24 healthcare provider organizations around the country working with the communities to try to come up with nonpartisan public health approaches to firearm injury. And that's now a part of the Aspen Institute. In addition, Megan was the inaugural director of the Brown Lifespan Center for Digital Health and Get Us PPE, which was an organization during the pandemic which delivered over 20 million pieces of PPE nationwide during the pandemic. Megan is really a visionary leader in public health and in society, I would say, and she's really recognized for her ability to communicate about what the evidence is in science and health and do so honestly, accurately, and empathetically. And we're really fortunate to have her here to speak with us today. I hope everybody will stick around afterwards. We're gonna have a short reception for Megan. And I'd also like to leave her with a little bit of swag from Division of PCCSM.
Thank you.
You'll have to wear that with pride.
Oh, thank you. Okay. Thank you, Luke. I really appreciate it. I'm going to have you rewrite my bio for me. That was really kind. Thank you. With one edit, which was 2.5 years in Peace Corps. So which was lovely. But it is an absolute delight to be here with you all. As Luke mentioned, I am, in addition to being dean and emergency physician, have started working at York Street. And so you may run into me in the ED with knowing nothing because I'm still getting used to the system here. And I'm just tremendously grateful for you all. Those of you that I have intersected with in the ED have been kind and supportive and unbelievably patient focused. And I'm really, really grateful for that. The culture here of support for each other has really impressed me. So it's a joy to join you today. So let's see if I can move these forward. There we go. So as Luke said, I'm going to be talking today about firearm injury and its ripple effects, some insights and opportunities from the perspective of public health, but I'll hopefully offer some things, not just that we can do on a societal level, but also some individual level actions that we can take as humans, but also as clinicians. I do have disclosures. As Luke mentioned, I have NIH and CDC research support for some of the work I'll talk about today, uncompensated advisory roles for 2 related organizations, and serve as on the board of directors of the Nonviolence Institute, which is a community violence intervention program in Providence, Rhode Island, where I spent the last 20 years, as well as serving as a trustee for the National Opioid Abatement Trust. So with that as a prologue. So when I talk about gun violence as a public health problem, as an emergency physician, this is why people think I am talking about gun violence, right? And this is, of course, the reality of our lives in emergency medicine. I know I have Jim Doddington here, a fellow emergency physician. We, as emergency physicians in the United States, choose our residencies in part based off of the prevalence of penetrating trauma that we'll see, because it is such a core part of our but just true bread and butter of our practice, regardless of where we are long-term. And so this acute resuscitation, the acute response to a GSW is of course part of what has driven me to do this work. And I often share stories about some of the patient experiences I've had that were part of my journey into taking on gun violence in particular, as opposed to violence in general, as a core issue for my research. But as I'll talk about a little bit over the course of the next 40 minutes or so, there are other impacts of gun violence as well that inform my work on this topic. One of them is it's both upstream drivers and downstream ripple effects. And I know that you as critical care docs certainly see some of these, whether it's someone who's paralyzed and has bed sores and then gets recurrent kind of has sepsis or develops spinal shock and you're consulted into the SICU, or whether it's the mental and emotional downstream effects of a gunshot wound, not just for the patient, but also for their family and community. As an emergency physician, I see all of those quite acutely as well. And then there's the effect on us as providers. Talking to Jim, I know that just yesterday there were 2 shootings of youth here in New Haven. And we don't talk a lot about the effect on us of caring for those patients. I have multiple friends who have left the practice of emergency medicine, particularly Black physicians, because of the trauma of taking care of people who could be their siblings or their cousins and its repeated effects. I have other friends that have left the practice of emergency medicine after being on call in Newton, in Aurora, or in any of the other places across the US where we've had horrific mass shootings. And I want to acknowledge also that for many of us, this is a personal issue. This is a picture of Dr. Tamara O'Neill, a fellow emergency physician who was shot and killed by her former fiance as she left an emergency department shift at Mercy Hospital in Chicago a few years ago. I put her picture up both because she was an outstanding human and because it reminds us of the ways in which this touches all of us, whether through domestic violence, through gun suicide, or through having friends or family members who've been present at shootings. Just today, I'm sure all of you heard that the CEO of United Healthcare was shot and killed in New York City. And there's plenty of stories of us physicians being shot by patients across the United States as well. So it does have a very personal resonance in addition to the larger societal impact. So those are the sad reasons that I talk about this. But the other reason that I talk about it is because I believe that there's hope. And to me, where I find hope is from the public health approach. As Luke said, I have spent my career not just as an emergency physician, but as a public health practitioner and researcher. And the reason that I do that is because it provides us a framework for creating change. The public health approach, for those of you in the room who may not have your MPH or your MS, right, is 4 basic steps. The first is that we gather data on the prevalence and incidence of the problem, basic epi. We talk about this as surveillance when we're talking in the public health world, but when I say surveillance outside of my world, people think I'm like the government monitoring them. So I've learned to not use that word when I talk about gun violence. The second thing is that we identify risk and protective factors, right? So we say, all right, this is how common it is. And then we look at all other things being equal, what puts someone at higher risk of getting shot or of dying, or what protects them, all other things being equal. We can also look at those risk and protective factors for those downstream effects. So if you are shot, what puts you at higher risk of being shot again? Or what helps protect you from some of those after effects of a shooting? What helps protect your family and your community as well? Once we've done those first 2 steps, we of course develop and evaluate interventions, which, as I will talk about, can range from the very individual level, one-on-one type intervention, either upstream long before a shooting happens, at the time of a shooting or afterwards, or we can develop and evaluate interventions that exist on a broader societal level. That's all part of kind of the public health approach. And then once we figure out what works, we implement, and then we go back around. For those of you that work with IHI, right, the Institute for Healthcare Improvement, it's similar to their PDSA cycle. So a very standard approach that we use and that we've shown over and over again works. And this graph is one of my favorites. It shows just how well the public health approach works. Just to orient you, the x-axis is years in 5-year increments. The y-axis is rate per 100,000, so population corrected, because of course our US population has gone up since 1965. And you can look at the yellow line, which is the rate of car crash deaths, the blue line, which is the rate of HIV/AIDS deaths, and then the red line, which is the rate of firearm deaths. Car crashes have dropped, or car crash deaths have dropped by approximately 70% since I was born. And we've done that, of course, not by taking cars off the road, but rather by using this public health approach to measure car crash deaths. We have NHTSA, we have the Fatality Accident Reporting System. So we've done that basic EPI. We've looked at risk and protective factors, identified, for example, that drunk driving is a risk factor, or for those of you that were in practice kind of pre-1985, that lack of seat belts or the steering wheels that impaled you were risk factors for injury and death. We've developed and evaluated interventions that make a difference, ranging from the mandatory driver's ed that my daughter went through last weekend before she gets her permit, to the car seats that we make parents go home with from the hospital, right? Those are all interventions that make a difference. Other types of interventions for car crash deaths are things like Ubers or Lyfts. There have been studies showing that we see decreased rates of car crashes in general and car crash deaths in particular after rideshare services are introduced because it reduces drunk driving. So a variety of public health interventions, all informed by data on incidence, prevalence, and risk that have reduced our car crash deaths since 1965. HIV, same thing, right? Obviously, Anthony Fauci and Gallo and others discovered the HIV virus, which yes, does cause AIDS, not up for debate, despite some folks in the news right now who are saying otherwise. We also used great science to develop antiretrovirals. But then there was a lot of public health science involved, and I know some of you are involved in this work, with not just having the actual biomedical kind of physiological science defined, but also the behavior change that goes behind changing patterns of transmission. We know that abstinence only doesn't work, right? We know that just banning drugs doesn't work. We've learned that safe syringes, that harm reduction approaches, that education, availability of condoms, availability of PrEP all make a difference. Those have both decreased the incidence of HIV and have helped people to stay on meds for longer, making this a survivable chronic disease for most. And then you compare that to our red line of firearms, which was up during the 80s and 90s in the midst of the drug wars, then went down, and then has been going up again ever since about 2006. And part of my underlying thesis here is that it's because we have not systematically applied that 4-step public health approach to firearm injury. Going into that rising rate in a little bit more detail, we talk about gun violence, and people think of gun violence as being mass shootings, right? Like that's the first thing you think about, especially here in Connecticut, we think about Sandy Hook. And that's a real problem, and we are seeing an increase in mass shootings nationwide. But even with the increase, it still only makes up about 1 or 2% of gun deaths per year. Where we've seen real increases are in firearm suicide deaths. Since around 2005, 2006, firearm suicide is consistently the top reason why people die of a gunshot wound. We just don't see it often because they die before they come to the emergency department, and has been rising dramatically amongst all populations. We've seen increases in homicide deaths, largely community violence, some intimate partner violence. That's been rising since about 2014. There was obviously a really dramatic rise during COVID, which I can talk a little bit about. It's come down a little since, but it's still higher than it was pre-pandemic. And then there are the unintentional or quote unquote accidental firearm deaths, mostly kids, right, who shoot a friend or someone else, a family member by accident because they find an unsecured firearm. Sometimes also one of the things that we've taken care of in the emergency department is the person who puts their firearm in their pant pocket without having the safety on, right? Those are unintentional firearm injuries and death, have stayed pretty steady over time. That's the population-wide. If I look going into my epi in a little more detail, this is a picture amongst kids, or this graph is amongst kids, looking at trends in homicide, suicide, unintentional, and then legal intervention separated out, firearm deaths among children in the United States from the year 2000 to 2020. And you can see among kids, a huge growth in firearm homicide, a pretty tremendous growth in firearm suicide as well, and increases in unintentional firearm deaths among kids in the US, to the point that in 2019 or 2020, depending on how you count, firearm injury became the leading cause of death for children and adolescents and young adults in the United States. That's not due to mass shootings, right? That is because of the homicides and suicides that our kids in the US are dying. Although again, the mass shootings are a horrific never event. Going in a little more in epi, on both of the two prior slides, I had a little bit about law enforcement or legal intervention involved firearm deaths. And I just want to put this slide up as a caveat, which is that we actually don't know a lot. They're very poorly coded, very difficult to suss out. But when you put various data sources together, on the left are the estimates of law enforcement involved firearm deaths from 4 different data sources. On the right is a meta-regression using the various data sources. And you can see that there has been an increase in LEO involved firearm deaths in the United States as well. And there's some further, of course, data showing that that's disproportionately, the burden of that is disproportionately among Black and Hispanic men. When you talk about the epidemiology of firearm injury, and I've got just a few more slides on the kind of step 1 of gathering data and looking at risk, and step 2 of risk and protective factors. When you talk about gun violence, another huge assumption that I hear over and over is the idea that this is a problem of urban centers. Yes, we have high gun death rates here in the city of New Haven. But if you look nationally, the states with the highest gun death rates are not necessarily the states with the greatest concentration of urban centers. It's a myth that persists in the United States. When you compare rural and urban counties, you find that many rural counties have higher gun death rates than urban counties, largely due to suicide, but also intimate partner homicide and community homicide. And the states, the darker red on here, the states with the highest gun death rates in our country are Louisiana, Mississippi, Missouri, New Mexico, Montana, Wyoming, right? States that are not huge population centers. That's really something that affects all of us. I'll highlight, there's that little kind of salmon color, very, very light salmon, northeast up in the upper right, Rhode Island, where I was, Connecticut here, New York. We have some of the lowest gun death rates in the country, but still an order of magnitude higher than in most other developed countries in the world. You can go in a little deeper if I'm starting to think about risk and protective factors when you think about the distribution of gun deaths across the US, to look at specific counties. This is a great paper by some colleagues at Penn looking at high outliers, so counties that have higher than expected gun death rates, all other things being equal, and then counties with lower than expected gun death rates. Those are really interesting to look at when we start thinking about risk and protective factors. What puts people at higher risk in some counties than others, and what's protective in some of those low-risk counties? There's certainly an element of socioeconomic status or social vulnerability index, which makes a huge difference, but there may be other factors as well which we haven't identified yet. And one of those factors, as we go even more deeply into kind of local geographic risk factors, is of course where you live on a block by block basis. This is a map of Philadelphia. They do a wonderful job in Philly of tracking shootings in real time and mapping them on so that you can visualize hotspots of shootings as well as gun deaths. And you see, I don't know, have any of you lived in Philly? A bunch of, yes, of course. Right, and so you know kind of the areas, you're looking in the places where there are lots of shooting victims are generally socioeconomically deprived areas, often primarily minority areas. And it turns out you can actually map them onto the areas that were redlined. So there have been studies showing that when you go really granular within cities, there is a strong, not complete, but a strong correlation between historical redlining and current concentration of firearm homicide. So there's these historical factors which drive whether you are likely to be a shooting victim in your own neighborhood or not, that has something to do with your present day conditions, but also may not. And so again, as I think about risk and protective factors, this is another level of thinking about that risk of where you live influencing your likelihood of being shot. And that's true, of course, here in New Haven as well, as we think about the quote unquote urban renewal project of the 1960s that has resulted in neighborhoods around our hospital system, Dixwell, the Hill, having disproportionate rates of shooting. Those are also the neighborhoods that were both affected by urban renewal and affected by redlining. Two more things within that kind of surveillance or basic epi and then risk and protective factors. I would be naive to not talk about access to a firearm as being a major risk factor for firearm injury and death. If there is no gun, there can be no shooting that hurts someone, right? In the US, we currently have around 400 million guns in private hands. About 40% of households have a firearm. Interestingly, that percentage of households that have a firearm has stayed pretty steady since the 1950s. But what we've seen is an increasing concentration of firearms, an increasing number of firearms in the houses that do have a gun. So it's, if you look back at Gallup data going back to the 50s and 60s, it's always been somewhere between like 38 and 42%. We're now seeing most gun owners now own more guns. In the US, we've seen a transition around the reason that people own guns as well. It used to be when you surveyed people, they would say that they own guns because they did for hunting or because of heritage, and a proportion of people would say they owned a firearm for personal protection. Now, the vast majority of people, 72%, say that personal protection is a major reason for them owning a firearm. So that changes the patterns of how people own and store and carry their guns. And we've seen a lot of new first-time gun owners. This data of 7.5 million new gun owners during the course of the pandemic comes from colleagues of mine at Harvard and at Northeastern. There's more recent data that's coming out that's not yet peer-reviewed, talking about rises in gun ownership just over the past few months in kind of due to fears around political unrest and civil war here in the United States. And we're finding that new first-time gun owners are different from the folks that were traditionally gun owners in the US. Traditionally, it was mostly white men. Now we're seeing an increasing number of women, Black and Hispanic people, younger people who are buying firearms. We're also, again, in kind of some initial data that I'm hearing from some of my colleagues, hearing about increasing proportions of LGBTQ+ people and people who identify as Muslim or Jewish buying firearms for the first time, again, out of that desire for personal protection. Other studies show that folks who are buying firearms for the first time now are less likely to have taken a safety course than others. And we're seeing trends around safe storage of firearms that are suggesting that people are less likely to be storing their gun in a way that keeps them and their family safe. So another big risk factor as I'm thinking about why people are getting shot. And finally, as I think about risk and protective factors in basic epidemiology, I do think about mental health. There's lots of language out there about how mental illness is the cause of gun violence. And yes, suicide is the leading cause of gun death, which is of course inextricably tied to mental illness. But when people talk about mental illness, they're usually talking about mass shootings. And the data actually shows that people who commit mass shootings have only a slightly higher rate of pre-existing mental health conditions than people that don't commit mass shootings. Most of them do have a noticeable crisis and or have a prior criminal history. Where there's a real relationship between mental health and firearm injury is in the after effects. This is a study from colleagues at MGH showing that amongst kids who are survivors of a shooting, we see a dramatic rise in pain disorders, psychiatric disorders, and substance use disorders, both diagnosed at the time of a shooting, but also in the aftermath. And we also see a rise in psychiatric disorders amongst family members, which is a really important thing for us to keep in mind as we think about the impact of this epidemic on our communities. Finally, we see an increase in stress, depression, and anxiety in communities in general after mass shootings. This study looked at social media data showing a rise in terms related to anxiety, stress, and depression. This is actually after school shooter drills, but there have been similar studies after mass shootings, and similar studies showing changes in kids' performance in school and kids showing up in emergency departments for mental health problems after a shooting in their neighborhood. So they're not just personal effects, but also these distal effects. Okay, so that's the epi. That's like all the facts and numbers for the most part that I'm going to show you for the talk. I'm now going to move into gathering data, risk and protective factors. What types of interventions can we consider? I'm going to get through this in about 10 minutes and then close up so that we can have time for questions and answers. So as I'm thinking about interventions to stop gun violence in the United States, right, I've just presented a lot of data about who's at risk and some of those kind of early signals of who what some of those risk and protective factors might be. As I start thinking about interventions, as I've already alluded to, I can think about them on the individual level, stuff I can do one-on-one, on the relationship level or the family level, community, and then societal level. I'm going to talk through some examples of each of those in turn. On the individual level, there's a lot of work that folks are doing, including myself, around thinking about how we change conflict resolution skills and also address some of the depression, anxiety that drives fights and likelihood of gun violence. So I have a study that is looking at text messaging for kids who've been in prior physical fights, which is a known risk factor for future fights as well as eventual firearm injury. And we've shown that by having bidirectional automated text messaging, we can improve their anxiety, improve their depression, and decrease the number of fights that the highest risk kids get into after an 8-week bidirectional program. We're also doing work looking at the impact of social media on an individual level on kids getting in fights. This slide is from Pew Research Center, shows the most common types of social media being used by kids, YouTube and TikTok being the top 2, both of them only being measured since 2022. I don't know how many of you guys have kids, but mine, despite my trying to set rules around social media, they use it a lot. And one of the things that we found is that kids use social media for lots of reasons that are good, but also lots of reasons that are bad, right? They use it to bully each other. They use it to egg on fights. They'll record videos and post them online. They'll really torture other kids and cyberbully them online. And so we've done studies looking at, can you design interventions using social media for kids who are either victims or perpetrators of bullying to try to decrease the in-person physical fights. And have shown that using social media and remote-based interventions, you can improve, again, stress, depression, anxiety, improve conflict management skills, improve their likelihood of stopping others from bullying, and reduce the physical fights that kids get in real life. So there are some lovely kind of psychology-based, motivational interviewing and CBT-based, very individual level interventions that are showing some promise in reducing some of these precursors of gun violence. Moving on to the relationship level. Another study that I'm involved in is something called Guardians for Health, funded by the CDC. We were part of the first tranche of CDC funding for this issue after 24 years of it being frozen. And we're working with 4-H, which I'm from Buffalo, New York. 4-H was a big part of life growing up. For those who aren't familiar with it, it's a kind of youth development organization that works primarily with rural kids, also with some urban kids based out of land-grant universities nationwide. We've done a randomized controlled trial of a bystander intervention program for kids in 4-H shooting sports who have high exposure to firearms, teaching them how to recognize risk factors in their community and know what to do if they notice that someone's at risk of suicide, domestic violence, et cetera. In a community with lots of guns, of course, they're going to be at higher risk of that turning into a shooting. We've just completed preliminary analysis of our RCT, have shown a significant effect on changes in knowledge, and our sample size was 1/5 of what we had wanted, but had a nearly significant effect on perceived behavioral control and behavioral intention, which was as good as we were hoping for, showing the way in which these kids can have a role in a relationship in their community and helping to address risk factors for gun violence and then potentially stop it down the road. Another really important place for relationships, of course, is our job as healthcare providers, right? We have a lot that we can do in the same way that my kids in 4-H can make a difference in terms of recognizing risk factors and saying something about it. We as healthcare providers can recognize and say something about risk factors for firearm injury. This is a picture of an amazing, amazing resource from my colleagues at UC Davis called Bullet Points that really takes you through step by step why you should talk to patients, how, and what you should do if you do identify that someone has a gun in their home and is at risk. I recommend that you go to it if you're interested in learning more, but I'll give you a really short version, which is that there are 4 really big things that we're looking at right now as risk factors for gun violence death. Domestic violence is one of the largest. If someone is a victim of domestic violence and their partner or they have a firearm in the house, their risk of death goes up about 5 times. If someone discloses that they are a victim of domestic violence or a perpetrator, you need to ask them about firearm access, make sure that firearm is secured, and help them think more actively about safety planning. People with depression or suicidal thoughts. Another big group that it is really important to screen for firearm access. I never learned in med school or residency about guns as a risk factor for suicide death. It is not a hard thing to ask about, right? Someone says, I'm feeling depressed, you know all the normal questions. Have you ever made an attempt before? Are you currently suicidal? Do you have a plan? Do you own or have access to a gun? It rolls off the tongue in the context of the other questions that we ask. And if they say yes, it both increases your concern, right? So may change your plans for hospitalization, but also may lead you to take other actions. And I'll give you an example. I had, just before I left Brown, a police officer who I took care of in my emergency department who did not otherwise meet criteria for hospitalization for his depressive symptoms and passive suicidality, but was a police officer, clearly has access to a firearm. I was uncomfortable sending him home. What I ended up doing was having his wife lock up his firearm in a safe that they had in his house and take the key. So he couldn't access it. He went on to get treatment, be fine, actually came back and visited me, and the ED was doing well. There are a lot of steps that we can take in order to help folks with risk. And I'll talk about one other step at the end of my talk. Dementia is a third risk. 40% of households have a gun. Lots of people are getting Alzheimer's and related dementia, big risk factor for firearm death for themselves and others, both suicide, but also from behavioral disturbances, and then of course, prior fights. And we've shown that we can, so as we've been developing kind of this culture of we as healthcare practitioners can intervene for firearm injury, we've been showing that we can train ourselves on how to do it. So this is a study, again, out of friends at MGH, showing that you can indeed train residents on how to screen for and intervene on risk factors for firearm injury. We've done similar studies with med students. And there's an ongoing study right now from friends at Northwell looking at universal screening for firearm access in the emergency department setting, then with structured interventions after people have been identified as being at risk. I could talk about PEDS part of it too. Most of you are treating adult patients, but I will say in this risk factor, obviously, if someone has a kid at home, making sure that a firearm is locked up safely is a good individual level intervention. All right. That's relationship. How about on a community level? On a community level, there are lots and lots of programs that are out there that have been shown with variable levels of success to make a difference in reducing the risk of gun violence acutely, as well as the risk of recurrent gun violence. I, of course, have our own Yale New Haven Health Violence Intervention Program up here. There's other community-based programs here in New Haven, but we generally think about these both in terms of hospital-based, community-based, or hotspot-based interventions. And knowing that you guys will have some intersection with them, I think it's worth showing that hospital-based violence intervention programs do have strong data showing that they work for people who engage with the program. People that don't engage, obviously it doesn't help. But for those who do engage, this is one study and there are others as well showing that they make a difference. Hotspot models, there's some mixed data, but they have shown reductions where you identify the people that are highest risk or the places that are highest risk. And then one of the things that I think is most promising on the community level are mentoring and intervention programs, which show tremendous effect sizes that have been repeated over and over across the US. Programs like 4-H, but also Big Brothers, Big Sisters, Boys and Girls Clubs, and other community mentoring programs have a huge impact on rates of gun violence because someone has someone to talk to, it gets them off the streets, it helps them with conflict resolution, and it's one of our hypotheses for why we saw gun homicide increase so dramatically during COVID. Final, community-based is the thought of us looking out for each other on a community, on school or on hospital system levels. Learning about, again, how do we watch out for those risk factors within our community? If you remember that slide around mass shooters, most people were in a crisis before they shot someone in a mass shooting. And the Say Something program developed with Sandy Hook Promise has shown that you can apply this community level awareness in school systems with great success in averting both firearm suicide and mass shootings. All right, final group of interventions that have data are societal. Those of you that are behavior scientists in the room, you know there's an individual versus a structural frame for interventions. Lots of individual stuff is helpful, but the systems or structural stuff has greater effect size, often with less effort. That's policies or procedures that are put in place on a big scale, right? So instead of just sending people reminders for meds, you make meds cheaper, for example. For guns too, society-wide policies make a difference. This chart comes from the Rand Corporation. Friends of mine there have done unbelievable work on synthesizing the literature around the effect, with the wideness of the band as the confidence interval, the effect of various policies on different types of gun injury and death. Blue shows that it decreases it, orange shows that it increases it. This is really, really helpful data as we are considering what policies to put in place on state and local levels, knowing that the federal level is largely closed off for the time being. But most of these policies are put in place on state and local levels, right? Stand your ground and concealed carry laws are almost exclusively state laws right now. So there is a huge role of policy, but policy alone is not enough. And I'm going to talk about one policy in particular that is very applicable to all of you, and I would say to all of us personally, as well as in our role as healthcare providers. Red flag laws. Who here has heard of them? Anyone? A couple. Okay, also known as extreme risk protection orders. The idea behind these, Connecticut was the first state in the country to have a red flag law pre-Sandy Hook. The idea behind a red flag law is that it allows someone, law enforcement, family, healthcare, to alert the system, get an ex parte order, so basically like a domestic violence restraining order. You get to go and get an emergency order to remove firearms from someone's house when they are at the very highest risk of hurting themselves or someone else. So it relies on a lot of those things I've already talked about, which are recognizing risk factors for injury and death. But when they are used, they have been shown here in Connecticut to decrease gun suicide deaths by 10%. And in other states as well have been shown to have a significant effect on gun suicide, some effect on gun homicide, and lots of case reports of efficacy for mass shootings. Those are tough to measure statistically because they are so rare. But they are a tremendously effective law, and we have one in Connecticut. And I expected that most of you probably wouldn't know that it existed because most of us don't learn about this. So this is the application form for risk protection orders in Connecticut. Since 2022, we as healthcare professionals have been able to petition to get a risk protection order without needing to contact the police directly. You can petition right into the judicial branch. You're probably going to have to call risk management to get them involved, but it is possible for us to do this and to let families know that they can do this. Again, particularly useful for suicide, but also potentially for mass shootings and for homicide. It is an incredibly effective and tremendously underused policy in Connecticut as well as nationwide. We see wide differentials in how it is used according to what law enforcement knows about it. So for example, in Colorado has a statewide red flag law. We see 10 times the number of red flag petitions in Denver County compared to El Paso County, despite similar population levels, simply because the sheriffs in El Paso County don't really believe in it, and there hasn't been a lot of education of families, et cetera, when there is a crisis moment. So I just want you guys to know about this because it is something tremendously effective on the policy level that we play a part in. And it makes a difference because when we look at whether policies are effective or not, a big part of it is how they're enforced and used. So knowing that this exists, if you're uncomfortable with it, you can go to the website, Google it, and hopefully you'll never have to, but chances are over the course of our career, right, it's something that we'll need to use once or twice. Last thing when I talk about structural interventions is thinking about structure on a bigger level. When I talk about risk and protective factors, when I went back to those slides showing where gun deaths concentrated and talking about how they concentrated in certain disinvested areas or areas that had been historically and on an ongoing basis are victims of structural racism and redlining, we can actually look, and we had someone visiting yesterday who gave us a lovely talk about this, but you can look and see much higher rates of gun deaths in areas with lower tree cover, higher rates of dilapidated or vacant buildings, higher rates of vacant lots. So there have been a number of studies across the United States showing that when you change that built environment, when you put gardens in place, when you knock down abandoned buildings, when you rebuild vacant buildings, that you see a significant decrease in gun violence, but also in stress and depression in the neighborhood around where that environmental change is made. Similar results for streetlights and other things. Doesn't fully make up for all the other stuff that puts people at risk, but it is a real intervention that can make a real effect. So here at Yale, at our School of Public Health, in partnership with many of you here at the med school, at the law school, and elsewhere, we are trying to do this work and put this full spectrum of individual, relationship, community, and society level interventions in place to try to make New Haven and Connecticut safer, but also to build an evidence base that we can use on local levels nationwide, as well as maybe on national levels, depending on how things go politically. The picture at the top is a woman who we were very proud to hire a year ago, Nelba Marquez Green. She is a lifelong Connecticut resident, well, born in Puerto Rico, grew up in Hartford, first experience with gun violence when she was a little kid, grew up, became a licensed marriage and family therapist. Her husband is a jazz musician, and they said, we're gonna move out of Hartford. They moved to Newtown, put their kids in school at Sandy Hook, and she lost her first grader in Sandy Hook. She has become a powerful voice for the value of communities and overcoming the gap of grief and injustice that leads to both firearm injury and its after effects. And she's helping us here at Yale to create partnerships. The picture at the bottom is of a number of our community partners across New Haven and Connecticut to help create partnerships across the state with folks who have been survivors in one way or another, but also to create partnerships with those who are helping to make a difference. Together, we're both creating trust within communities, listening to communities around what types of interventions along that spectrum are most likely to make a difference, and then creating funding to help support the implementation and the evaluation. And so I will close with this note, which is about funding. This is a study that a couple of my mentees and I, along with Tony Tong, who's in your Department of Cardiology, did earlier last year, looking at changes in funding and then changes in publications and clinical trials related to gun violence. When I started my residency, it was very soon after the first A line on this graph, which was, of course, the Dickey Amendment. Dickey Amendment was this thing that basically stopped federal funding for firearm injury prevention for 24 years. It wasn't an explicit ban on the government funding firearm injury prevention research, but served that purpose. All the money was taken away from the CDC and then the NIH that they had been spending on this issue. As a result, firearm injury prevention received less than 2% of the funding that sepsis received. You guys are a bunch of critical care physicians. You care a lot about sepsis, but sepsis kills about the same number of people as guns do a year, and yet we had 2% of the funding. And so because of the lack of funding, when I started my career, despite doing an injury prevention fellowship, and that was what my postdoc was in, I was told very explicitly to not talk about guns because it would doom my career as an academic researcher. And I was not alone, right? So around 2006, 2007, a group of us who had kind of gone through training said, this is kind of crazy, right? That was when we were starting to see that uptick in injuries and deaths. And we said, why are we not applying these tools that we know work for other public health problems we started to create some coalitions. It was like a dozen people across the United States that were trying to apply the public health model and do research. After Sandy Hook line B, the Dickey Amendment was clarified. It was said, no, actually, you can do the research. Then we tried again in 2013. And then in 2019, finally, Secretary Alex Azar under Trump agreed that we could fund firearm injury research. And in 2020, the funding was released, $12.5 million to CDC, $12.5 million to NIH. We've had the same thing ever since. Not a lot for those of you that work in other areas, but better than nothing. And as a result of that very small tranche of federal funding, we've now seen dozens to literally hundreds of people enter the field. Next week, I'm going to be in Seattle for our 3rd ever Research Society for the Prevention of Firearm-Related Harms. We have about 600 people that are attending. Funding matters. People, you all know this. You entered your area of research partly because you love it, but also partly because you could get federal funding to do the work. I am deeply worried about what happens if and when funding disappears again. And so I would encourage you all to join me, as we did back in 2019 when we had the This Is Our Lane campaign, to help make sure that we don't get this funding cut, because it will put us right back where we were. All the data that I just presented was from post 2017, 2018. Virtually none of the data that I've just presented over the last 45 minutes happened before 2018. And more than half of that data is post 2020. And we're going to see a lot more come out in the next couple of years. So funding matters deeply. So to close, if I can leave you with anything, 3 steps to take to address firearm injury using the public health approach. The first is to know the facts, that basic epi that I shared around who's affected and why, and also the facts around what types of interventions are likely to make a difference. The second part is to share your stories about why this matters, either the personal stories from your own life or the stories from you as a provider. And then the third is to help take action. You can take that action on the one-on-one basis in the clinic or in the ICU. You may take action in supporting community programming, in supporting Jim and the hospital violence intervention program, in working with us in research, or you may take action on a larger societal level, thinking about policies and their implementation, community mentoring programs, and so on. But the only way we make progress is by us doing all 3 of those. And I can say with certainty that when we do those 3, we do see progress. Not necessarily so much here so far in New Haven, although Jim is fighting the good fight and we're trying hard, and we have a new gun violence prevention task force with the mayor. But on a national level, I have lots of success stories of places where we've done this in both red and blue communities. And gosh, right now it is up to us. So with that, thank you. Thanks for coming, and it's a joy to meet you all. And as promised, I left some time for questions.
Yes, thank you. Let's hear from Clark.
That was fascinating. Thank you so much. So I was going to add another epidemiologic factor that I think is under-investigated, and something I stumbled into in my own research in opioid use disorder that I think may have some implications. That is time of day that some of these events are occurring. And there's some really convincing epidemiologic evidence that when you adjust for the proportion of population that is actually awake at nighttime, the rates of homicide, the rates of suicide, the rates of overdose, the rates of eating disorder just go through the roof. I think this has some really interesting science behind it as well. There's the whole phenomenon called the mind after midnight phenomenon.
I tell my 16-year-old about that all the time. So
I know, exactly. 100% true.
Increase creativity.
No, the opposite. Don't listen to Naftali.
Nothing good. Yeah.
After midnight.
I see his now his blue sky posts, not Twitter anymore.
It totally depends on your underlying circadian rhythmicity. And so when you are awake, during your biologic night, the areas of the brain that control executive function, that control mood regulation, that control reward, impulsivity, reasoning, shut down. And this is an explanation for why a lot of these events. And I think particularly at the individual level, there might be some potential therapeutic opportunities there to help with this.
That's awesome. Thank you. That's a really interesting association that I had not heard before and would love to talk more. I will actually mention a couple. So heat is another one that I didn't mention that we actually have strong relation. Not surprising, right? We all know on hot days, more people get stabbed and shot, but there's now been kind of actual strong quantitative demonstration of that association. Another one that we're increasingly looking into, and one of my PhD students who's still at Brown is going to spend his career on this, is looking at the association between lead exposure and violence, right? We know all of us learned lead poisoning and all the bad things that it does and how boys versus girls, it has different effects, with aggression being a major after effect. You look at Flint, Gary, Indiana, some of the cities with the highest rates of gun violence. And so lead is another interesting one that there's some preliminary, really interesting data around that lead, L-E-A-D, lead, the element, like lead poisoning, you know, the teeth in our bones and yeah.
Megan,
Mark,
thank you.
yeah.
Thank you. So one thing that you didn't talk a lot about today, but I'm really interested in is the issue of legal restrictions on firearms. And, you know, I think that the obvious thing is that gun ownership is available legally in this country to such a great extent
Yeah.
compared to the rest of the world. And not just the issue, can you own one or not, but even just licensure and expectations for getting classes and things like that. And I'm wondering, is that our lane to talk about that?
I think everything is our lane to talk about with good data behind it, right? And this slide, I went back to the slide, which shows that when you have looser concealed carry laws, you see rates go up. When you have minimum age requirements, you see rates of firearm suicide go down. Waiting periods, you see suicide and violent crimes go down, background checks, right? So there is strong evidence between that association, between policies that have some basic safeguards in place around who owns a firearm or not, and rates of firearm death. Total side note, I talked a lot about death here. I didn't talk about injury because our epidemiological data on injury is frankly unbelievably poor quality. We're working on it, but that's why I talk about death instead of injury. One of the challenges, though, is that, again, we have 400 million guns in private hands right now. And so there's a lot of thought around also how do we put kind of training or tests in place? Like, are there things that we could do? Could we work with our psychology colleagues to think about how to at least make sure that there's some sort of, like with graduated driver's license or requirements for driver's ed, that there's some sort of a program in place where you have to go to a shooting range. You have to go and, you know, take certain courses. And that may in and of itself help to alert us to some folks that maybe shouldn't be firearm owners. So I think there's a lot of work to be done in that area. It's going to be a different type of discussion in some states versus others. And I think, you know, a lot of my work actually is with firearm owners and in states with high rates of firearm ownership. And there is a very real fear, and I'll put the analogy here around the fear that some of us have around reproductive rights, of there being a slippery slope. That if we put one law in place, it's going to be used as an excuse to eventually remove someone's ability to have firearms. I'm going to quote my 16-year-old again. She said to me the other day, her school put in place restrictions around them being able to use their home computer at school because they don't want kids going on bad websites. And she goes, Mom, this is only going to hurt the kids that were following the rules anyways. The kids that aren't following the rules are going to still find ways around it. And that's what I hear from firearm owners, right? Is this feeling of, we follow the rules. Why are you making it more onerous for us? So I think there is reality that the policies work, and we have to recognize how we are going to politically create change and how to put policies in place that do make sense and don't punish people who are law-abiding owners. Also make sure that they know about some of these risk factors, safe storage, how to watch out for their kids, et cetera. That's a very long answer. But ACP has been an outstanding leader in terms of work on this. So kudos to American College of Physicians and to ABIM Foundation as well.
Time for maybe one more question. Maybe I'll take the, no, yes. Kathleen.
Sorry. Thanks so much for that. I have a lot of thoughts about what you presented. It's really beautiful. There's a whole host of vulnerable populations I'm thinking about,
Yeah.
including Indigenous populations. I work with veterans.
I didn't even,
And-
so veterans, Native American populations,
Yeah.
also drastically higher rates of
But
firearm death.
I
but-
think it helps me get to the biggest like stress and source of despair that I'm feeling these last several weeks is that how do we change our messaging so that like people are going to hear it? Because I think that, you know, we are in a very privileged position and we are seeking to get this kind of wisdom from you imparted on us. And how do we though make it so that it's not so, this is not to say that your presentation is absolutely beautiful, but like
Don't worry.
maybe it's not relatable to people who are in Oklahoma and like,
Totally.
you know, trying to like, we're not very relatable sometimes in the
No, we're not.
academic world. So how do we do that? And especially with social media stressors and then tailor it for each of the groups that are going to be particularly at risk for bad outcomes.
Yep. So that is a bigger question that is honestly a whole other talk, and also one of our strategic priorities at our School of Public Health right now, as Luke knows, is around kind of this question of how do we create trust. And I mean, honestly, we're seeing with RFK Jr. that people care a lot about health. They just don't believe us, right? About what the drivers of health are. And yes, we would agree that processed foods are part of the problem and that lack of, but so there's a real disconnect for us in general. For this issue in particular, a couple of things. One is I am not the messenger. So for example, with 4-H, I have as a paid co-investigator on my study, the director of 4-H shooting sports, the national director of 4-H shooting sports, as well as a couple of 4-H shooting sports instructors. They're the ones who are talking about the study, trying to make it trusted, telling families, no, they're not going to take your guns away just because you participate in this study, right? So I am in no way, shape, or form the front face of that work. And I think that's part of it, is those partnerships. The second part is, if I go back to that slide around kind of HIV and cars, or if I think about what we learn about smoking cessation, or I think about what we learn about domestic violence, I think we do sometimes tend to come into these conversations with some judgment, right? And I will say 40% of physicians, like 40% of Americans, have a firearm in the home. And so a lot of my work has been creating partnerships with, I don't have a firearm in the home for personal reasons, but many do. And I think making sure that we have that respect for each other matters deeply. I would never talk to someone who has, right, we've learned a lot about like substance use disorder, how to have that harm reduction conversation in a way that's respectful. Doesn't mean I ever have to have used injection, you know, I'm not an IVDU, never have been, but I know how to have that conversation in my ED. And I think there's that same element for us as healthcare providers in terms of how we respect a portion of the population that we may not be able to personally have the same lived experiences at. And then the third part, there's this much bigger question about the language that we use in the messaging. If you were coming to Seattle, I would say we're actually doing a session on how to work with firearm owning communities and on messaging. And I think that that's part of it, is making sure, in the same way that a lot of us had pushed to have patients involved in conferences, right? The whole idea of PCORI. There's a similar thing here, whereas we talk about risk, we need to make sure that all voices are sitting at the table in the conferences, in the research, et cetera, which is not like whitewashing the danger, but also is done in a way that is more likely to result in positive change. But again, much, much bigger topic that I think that we have to grapple with, but also we can't give up on. So as you struggle with that hope, which I think many folks are feeling, to remind us that we are here for the health of all, we know how to do that. And it's a chance for us to reevaluate some of our messaging, but also not a time to give up, because like when we stop a resuscitation, right? That is the moment where all hope is lost. As long as we are still in the room, there's still hope to be had. And so I think that our voices and our actions matter more than ever. And it's a good moment to kind of recalibrate. So thank you for that question.
Thank you so much, Megan. Incredibly informative and inspiring.